My name is Peter Oliver. I'm a professor at the Faculty of Law. I'm co-director of our public law group and faculty advisor of the Ottawa Law Review. First, congratulations on fighting through the rain and the sleet and the snow to be here with us today. Et bienvenue à l'Université d'Ottawa. Welcome to the University of Ottawa and to the Ottawa Law Review Symposium on Drugs for Superbugs, Fighting Antibiotic Resistance in Canada. Each year, the Ottawa Law Review hosts an annual symposium about a pressing legal issue. Recent symposia have covered topical issues such as cloud computing and electoral reform.
La Revue de droit d'Ottawa a sélectionné le thème de la résistance antibiotique cette année afin de rassembler des membres de la communauté juridique, des professionnels et professionnelles de la santé, des gens responsables des politiques en matière de santé, ainsi que des étudiants et étudiantes, lesquels pourront nous offrir, selon une perspective interdisciplinaire, la voie à suivre face à ce problème imminent.
Antibiotic resistance poses one of the most significant challenges to controlling infectious diseases. This global issue engages many stakeholders, including civilians, policymakers, medical professionals, legal professionals, the pharmaceutical industry, the livestock industry, as well as government and non-government actors on a local, national, and global scale. We're very glad to welcome leading international scholars from across Canada and North America to discuss the issues surrounding antibiotic resistance and to propose innovative solutions and strategies for regulatory reform. And I wish you every success in your discussions today. I grew up in a medical family. My father was a urologist and associate professor at McGill University. My mother was an occupational therapist. There are four of us, and I have three sisters who are all health professionals, so how did I end up as a lawyer? Well, that's because around the dinner table, we occasionally talked about things that had happened in all of our days, including my father's days, which included stories, anonymous, of course, about a patient that he'd met who had traveled as a refugee from, incredible stories. There were also stories about spending 7 hours in the operating room and being tired, but it was mostly about issues of politics and policy, and history. Those are the things that I was interested in, but there was I remember one discussion, and this is in the 1970s, about my father explaining to us why it was that when you had a course of antibiotics, you had to finish that course of antibiotics even when you started feeling better. And that was really kind of drummed into us. And I remember as I had children, I was in the United Kingdom at the time, being a bit surprised when we were given antibiotics or our children were not being told the same message. Now, I'm sure at a conference like this, you'll want to tell me that it's much more complicated than that. So that isn't really the point. But the point is that I think the way forward for this incredibly important topic is to get the people who understand the science and the people who are working on policy together. And that's what's happened here today. And I congratulate those who conceived of the conference and the organizers on doing that. So before winding up, so that the symposium can get underway, there are a few thank yous that I know the Ottawa Law Review would like to make, and to do so through me. Nous aimerions d'abord remercier le laboratoire de stratégie mondiale, the Global Strategy Lab, le Centre de droit politique et éthique de la santé, the Center for Health Law, Policy and Ethics, ainsi que notre commanditaire, les instituts de recherche en santé au Canada, the Canadian Institutes of Health Research. So with that, I'll hand you over to the next stage, and I wish you an excellent symposium. Thanks very much.
Great. Bonjour à tous. Merci beaucoup pour cette opportunité, and thank you everyone for being here. So my name is Stephen Hoffman. I'm the director of the Global Strategy Lab here at the University of Ottawa, which is a research program that's based within the Center for Health Law, Policy and Ethics, a new initiative here that's directed by Professor Colleen Flood. It's really quite an honor, really, to be here, to be opening up this conference today, to be talking about this issue of antimicrobial resistance. This is an issue that is something that we at the Global Strategy Lab have been focused on for quite some time. But it's one also that it's the perfect timing for this kind of conference. There's a lot of discussion now. There's a lot of increasing public awareness about this issue. And so really, before I begin in setting the scene, I really want to give congratulations to the Ottawa Law Review, the whole student team that put this together. Not only for running such a great event, so professional, but also for doing it on a topic that really matters, and that matters right now. So congratulations to the students who organized this. So the conference is about antimicrobial resistance in Canada and what we can do about it. But before we talk about Canada, I think it makes sense to talk about antimicrobial resistance in the global context, so that as we do talk about strategies and different barriers and challenges that we face here at home, we understand the kind of issue and the extent of the issue that's faced around the world, and to what extent we're actually both constrained and empowered by what's happening outside of our own country. And so I will do that, and then I'll go through some ideas that have been discussed at the global level for what we can do, and then later sessions will follow through in terms of other kinds of things that can happen closer to home. So to start this issue, so superbugs, it's a dramatic title. I wish this problem was as cute and fuzzy as the Looney Tunes Bugs Bunny in a cape. It's not. This is a terrifying problem, one that all of us need to be thinking about, not just the scientists who study bacteria and viruses and other microbes every day, but all of us, any of us who care about our health and care about the health of others. So how does this work? What is this? So first, I just want to say that antimicrobial resistance is a natural process. This is something whereby bacteria and viruses and other microbes slowly develop resistance to the drugs on which we rely currently to combat disease. So what it means is that these bacteria, which are usually susceptible to drugs that we might use, penicillin and other antibiotics, antivirals, suddenly they slowly evolve over time to develop resistance to them, so that those drugs, they once worked, and then they slowly no longer work for various biological reasons. And the way that this made worse, though, is that if it happens in an environment without the use of drugs, then this process would happen quite slowly. The challenge is that we as humans are doing things that's actually artificially speeding up the pace of the development of antibiotic and antiviral resistance, which is really becoming then a huge global health challenge. And so in this figure, what you'll see, this is from the World Health Organization, they identify really two main ways in which antimicrobial resistance is spread. The first is looking down from the top left-hand corner, is that antibiotics and antivirals are given to patients, which then can result in drug-resistant microbes, which then can spread to other people when they attend in a hospital or a clinic, and then it can spread from there. The other main route is that antimicrobials are not only used in humans, they're also used in animals. And so animals are given antimicrobials, resistance, bacteria and viruses in animals then develop resistance, and there's contact between those animals and humans, and then it gets to humans that way. To delve in a bit more into how does this resistance actually work, let me give you an example. So the example would be, here you see on the left-hand side, this is antimicrobial resistance 101, by the way, trying to convey the science in 2 slides. This is the second of those slides. So on the left-hand side, you'll see that we live in a world where there's bacteria that are both susceptible to our existing drugs, as well as those that maybe by random chance have developed, let's say, a genetic mutation. That means that bacteria is no longer susceptible to the drug. For example, let's say our drugs, they work by going into a cell through a protein channel. What if by random chance we have a bacteria that has, let's say, a genetic defect whereby that protein channel no longer works? Now, usually, you have a defective protein channel. That's bad, right? It means that things that are supposed to get into that bacteria are not getting in. But what if that defect happens to also stop the entry of an antibiotic? What that means is then that bacteria, which is defective usually, actually becomes a superbacteria, a superbug. And so what you see then is, as usually the defective bacteria, which are the yellow, would not compete very well against the non-defective bacteria. So when they multiply, maybe don't multiply as fast. But then in the presence of an antibiotic, which is the third column, the bacteria that are susceptible to the drugs would die, but the ones that have that defect don't die. And so as a result, because they're now in an environment without many competitors, they multiply and go forth and on. So this is antimicrobial resistance science 101, explained in 2 slides. The reason this is all a problem is because the more that we use our antibiotics, the more resistance we see. And so just purely at a very macro level, you'll see that on the left, here's a graph that's showing on the bottom, it's the daily antibiotic use per 1,000 people. So it's per capita use of antibiotics on the bottom. And then on the top, it's the percentage of pneumonia-causing bacteria which are resistant to our available drugs. And so what you see, there's that correlation between those countries that use more antibiotics per person also face greater resistance in their populations. It's one example of many that I could show. The other challenge is that many of the antibiotics we take are not necessary. We're not using them as effectively as we should. So in one study in the US, they found that when people came to a doctor with a sore throat, we know there's about a 10% chance that sore throat is caused by a bacteria. Yet, 60% of patients were leaving American doctors' offices with an antibiotic prescription. And so just a flag, so antimicrobial resistance, the word microbial, it means that includes things like bacteria, viruses, and such. But an antibiotic, that's specific to bacteria. So if there's a 10% chance that something is caused by bacteria, yet 60% are getting a drug that's specifically for bacteria, that means that at the very least, 50% of these people who are leaving the doctor's offices are getting an inappropriate use of that antibiotic, and that's affecting all of us because it breeds resistance. The other part of the challenge is that the blame is not only on doctors. We have a situation whereby people often come to a doctor's office expecting a cure. And so what you see here is this is, again, an American study where doctors were surveyed and were asked were they ever pressured by a patient to prescribe an antibiotic when they didn't think it was needed. 55% of physicians said, yes, we've been pressured into doing so. And what's even worse is that 45% of doctors admitted that they prescribed an antibiotic when they knew or thought it was a viral infection. And then third, 44% of doctors admitted that the only reason that they prescribed the antibiotic was to get the patient to leave the room. So this is a problem which, it's a social problem which requires social solutions. It's not just humans. Right now, if you look at the total use of antimicrobials, 80% are actually used not in humans, but in animals. It's a complicated problem. The exact extent to which our use of antimicrobials in animals for various purposes is the extent to which it is. We don't know exactly how much it contributes to the problem, but we do know that it's a significant contributor. And so we definitely know that this is not just a human health issue, it's an animal health issue, which also then has human health consequences. And so part of this use would be high-value use in the sense that when animals are sick, of course, we want animals to make sure that they can get treatment that we know will work. But animals aren't only given antibiotics to cure or to treat a sickness. They're also given antibiotics as a prophylaxis measure, whereby if we give antibiotics in advance, it means that we don't have to worry about them getting sick in the future. So it's done as a prevention measure. But that means there's a lot of antibiotics being used to prevent disease that otherwise might not have happened. And also, there is a side effect of using antibiotics in animals, which is that they grow faster, they grow bigger, and they don't require as much food to do so. So in some respects, it's currently, given the price of antibiotics and the widespread availability, it's a cost-effective measure to increase farmers' yields. But there's a whole panel that will be discussing this further. And so just to emphasize, it's not even just humans and animals where these antimicrobials are being used. Here's an example of a health and data safety sheet. A material health and safety data sheet, which is highlighting the contents of a paint. And I've highlighted here that there's an antibiotic formula in this paint, which basically means that this company is putting antibiotics into paint, which is then in this case meant it's focused on the hull of ships. So I guess that's maybe good. I guess maybe ship hulls get mold, and maybe this will help. But I'm not sure about that. And at the very least, it is questionable whether this is a high-value use of our antibiotics, which are really quite a precious resource. Maybe you'll agree with me more that this is quite an egregious example. So here is the list in the United States of different antibiotics which are approved for use in agriculture products. And so what you see, I've highlighted here that the antibiotic streptomycin is approved for use on tobacco plants. And so what that means is in the United States and in other countries, we are literally spraying tobacco crops with our precious antibiotics so that our tobacco plants can be healthier and kill more people in a more cost-effective way. That's crazy. And at the very least, if people think it's not crazy, you'd probably agree this is a low-value use of our antimicrobials, which are so precious. So we have a problem. The consequences are severe. Right now, today, it's estimated that 700,000 people die from antimicrobial resistance worldwide. This is a problem that doesn't have a face, in that when people die from cancer or they die from any kind of infection, we usually blame it on the cancer, or we blame it on the particular infection. We don't usually talk about it being, oh, it was an infection it was a particular kind that was resistant, whereby the drugs that we tried, they didn't work. We don't usually think of it like that. And as a result, we don't have a body part or a disease organization that's advocating for this issue. It's a silent pandemic that's really a global in nature. And unfortunately, this problem is only going to get worse. And so it's been modeled that we think that by 2050, it won't be 700,000 people dying per year of this. It'll be 10 million people per year dying from this. And so that is more than diseases like cancer, quite a bit more. So this problem is a big problem now, and it's only getting worse. And I'll emphasize that even in Canada, we're a country that even if we try and do the best that we can, or if you're in the United States or in any other country, if you only look within your country and what they're doing, it's not a full solution to the problem, given that the way that we travel these days, these microbes that are resistant, they are not afraid of flying, and they do not carry passports for which our border control can stop them before entering a country. And so this map, what you see is the lines is the flight patterns. This is the way airplanes travel. And the dots is from a new study out in the Lancet last year that was showing which outbreaks of different infections were linked to international travel. So, and this is specifically which outbreaks of resistant bacteria were linked to international travel. And so you'll see there are some dots in Canada, but there's dots sort of everywhere around the world. So what this means is that even as much as we do domestically, the threat could still come from afar that needs to be addressed. And that's very different than in the past. So this is a figure showing the spread of disease during the 1300s in Europe. And instead of the last graph where it takes 17 hours to fly from Hong Kong to Toronto. So we're talking spread of disease in hours. So in the case of SARS, for example, 17 hours from Hong Kong to Toronto. This is how the bubonic plague spread across Europe in the 1300s, each color representing a different year. We used to track the spread of infection by the year. Now it's the hour. So the global nature of this problem is really quite clear. So the superbugs are coming. We know this is a problem. We know people are affected both in terms of death and morbidity. We know that this is something that requires an urgent attention. Yet, why aren't we seeing the necessary level of action? Why don't we all, why doesn't the whole world already know about this problem, and why aren't governments around the world seizing this challenge as something that needs to be addressed, just like we see discussion about other major threats like climate change or nuclear weapons or the state of the world's economy. And so I'll explain that it's actually, unfortunately, quite rational that we're seeing a bit of inaction. Rationality that hopefully we can change, but it is at least understandable, and I'll explain why. The first is that there's no silver bullet solution to this challenge, and I'll explain these more in depth in a second. But what that means is that there's interlocking action that's needed. There's no one thing we can do and just go ahead with. The second is that there are some very clear global market failures in that we over-provide antibiotics in some contexts, we under-provide them in others, and then there's insufficient innovation as well that the market is generating. And third, there's some clear global governance gaps, which results in collective action problems. So to go into more context, so no silver bullet. What I mean by that is that to address antimicrobial resistance, it's not really just one problem. We're actually faced with 3 problems. If we simplify, it's actually even more complicated than this. But to simplify, the 3 problems are access, conservation, and innovation. So in terms of access, what we see is that there's millions of people in the world who are still not able to benefit from our advances in technology, our advances, the development of antimicrobials. Millions of people who are sick, who have infections that could be addressed by antimicrobials, don't have access, either because they can't afford to pay or because insurance schemes don't cover. Most of those people, although not all, would be based in low and middle income countries. And so currently more people die from lack of access than the 700,000 people who die from antimicrobial resistance. The second part of the problem is conservation. That's that we have these existing drugs, and we need to do everything we can to ensure that they stay effective for as long as possible. And the third part is innovation, because even if we conserve what we already have, we still need new drugs to replace them, the existing ones, given that antimicrobial resistance is a natural phenomenon, and we will see resistance happen, regardless of how good we are. So we need new drugs in the pipeline. The problem is we can't address each of these challenges on their own. So not only do we have no silver bullet for the 3 problems, we can't actually even address them separately. It needs to be done in an interlocking way. And the reason for that is that we can't just address access, because access without conservation and without innovation actually just speeds up resistance. So if, for example, think of if we just provide access and we're not focused on making sure it's appropriate access, it could create circumstances where resistance goes up. Similarly, conservation, by trying to conserve the use, when by definition restricting access. So if we restrict access in cases where it's needed, that's really bad. But conservation also undermines innovation in the sense that it constrains the market. It creates a smaller market. Companies that are interested in selling as much product as they can for as high a price as possible would be less incentivized to develop new antibiotics and antivirals if they thought there were going to be restrictions on the sale of them. And the third is innovation without access is just unjust. It's just not fair that we develop new products and then people in the world don't have access to them when they need them. And innovation without conservation is wasteful, because why would we spend billions of dollars to develop new antimicrobials when if we just use them in inappropriate ways and then a couple years later they're already in some places not starting to work. So that's clear. We need action on all 3 simultaneously. The second problem is a global market failure. And for this, we can point to some game theoretic problems whereby states, when they're trying to act, it makes sense why they might not be doing as much as possible. And part of this is that there's some clear consequences of action. So basically, for states to take on action, it costs money, right? I mean, enacting new policies, conserving, investing in R&D, these are costly measures. And states also know, like countries like Canada know, that unless all other countries, or unless a lot of other countries also take action at the same time, then Canada won't fully benefit from its own costly action. And so what you see here is it's kind of like we see global commons dilemmas, we see negative externalities. So for example, we have a situation just like climate change, whereby we have this limited pool of antimicrobial effectiveness. So there's a limited pool of effectiveness. Each of us can draw on the pool unilaterally. Just like we have an environment, we have one ecosystem. We can only emit so much carbon dioxide before we have problems. And so the problem is that each individual is incentivized in the short term to draw on that common pool of antimicrobial effectiveness. even though that same individual, when we look from a population level, is incentivized to actually manage that resource and ensure that we're not drawing on that resource when it's inappropriate. So it creates this short-term individual incentive versus a long-term population-based incentive. And it's, well, we're human, we're rational. It would be rational at the individual level to draw on that resource. But unfortunately, there's consequences for everyone as a result. We would all be better off if we had a broader regulatory regime governing this. The same is true for access. So, for example, it's great if we promote access, and when we're sick, each of us might go to our doctor and want an antibiotic. But there are negative externalities to that, and the fact that it breeds resistance for other people and globally, not just in our own countries. And then, for example, with there's free rider problems, such that a country like Canada could argue, well, why would we invest so much money in developing a new antibiotic when the United States will spend the money, or the United Kingdom will put that money forward, and we can just free ride on their innovation, because once they develop something, we can get it. So that's a poisonous way of thinking, and it leads to the kind of global inaction we're thinking. Yet it's, in a sense, understandable for why people are thinking in that way, unfortunately. The third is that there's some clear global governance gaps. And so this is from a study that we did at the Global Strategy Lab, where we tried to map out different actors who were involved in this space and the kinds of functions that they were serving, or the kinds of policy issues they were trying to address. And so what you can see from this pretty chaotic map is that it is a chaotic global governance landscape. Lots of actors, lots of action, but insufficient coordination, insufficient compliance in that a lot of actors say they're going to do things and they don't follow through. Insufficient leadership. We're not seeing the main actors providing effective leadership for this space. And finally, there's insufficient financing. This problem is not getting the amount of funding that it needs. And so as a result, we see countries like Canada that have not fulfilled its responsibilities in this area. This is the Auditor General report that was published a year ago, just under a year ago, which flagged that the Public Health Agency of Canada and Health Canada have not fulfilled their responsibilities to mitigate this public health threat. This report is really I think, shone a light on the extent to which we had seen some talk about Canada doing work on antimicrobial resistance, but when the Auditor General went into it and looked at what are we actually doing, at least these two agencies of government were found to not be doing sufficient action. So that should get all Canadians very concerned. And that's one maybe an additional reason why a conference like this is so timely. So to summarize, we're in this epic battle between bacteria and antibiotics, between viruses and antivirals, and, well, in this case, the antibiotic seems to be doing pretty well. He's standing straight with his cape flying in the back, but we're not doing so well in this epic battle. And so we need new tools, we need new weapons to bring to bear so that we can win this war against antimicrobial resistance. And so some of us have been calling for that new tool to be international law. We think that international law has a role to play. Of course, we need other things. We need enormous increases in science. We need genomics research. We need new innovation around what kind of social policies can take place in hospitals and in the agriculture sector. We need lots of things. But one of the key challenges, which I've highlighted here, is that this is a global problem, and a global problem that's resulted in suboptimal and insufficient action by countries, and which needs a global solution to address it. So we think that there is a role for international law in addressing this issue. And so why international law? And so I'll point to 4 reasons why that might be the case. The first is that it's a clear issue of interdependence among countries. So this is an issue whereby even if we in Canada do all that we can to address this challenge, we won't be fully protected, given a resistant bacteria can just fly in from a different country. The second is that the interlocking actions are needed, which means that each action, we can't just act on it independently. We need a comprehensive solution to this issue, one which international law could provide. Third is that actions are costly, so we need each party, each country, to commit up front to delivering on what they promise to do. Or else other countries aren't going to necessarily want to act either. Why would any country want to commit to act unless they were as confident as they could be that other countries will do their part as well? And then there's this need to overcome the short-term versus the long-term interests that I described before, meaning that we need to lock in commitments and disincentivize deviation. And for that, the mechanism that it's not the strongest mechanism when we look globally. International law, it's a pretty weak mechanism, but it's the strongest we have when it comes to global governance. And so it's not perfect, but it's the best that's available. So we think there's a role for international law. Now, it's easy to say international law, but international law is just a vehicle. It's just really a way that we package things together. What really matters is what's inside of the international law. What does the international law require? And so we can break that up into two different things. First is the content, so the actual, what are the things that countries would be agreeing to do, taking on? And the second thing is the implementation mechanisms. So how do we ensure countries actually do what they say they're going to do? And these can be divided up. So content, it can be divided up by access, conservation, innovation. On implementation, we can think about it as changing institutions, changing incentives, or mobilizing interests. And so there's increasing research that's coming out. There's a whole series in the Lancet about what kind of content there should be. There's been some of our own studies at the Global Strategy Lab about what kinds of implementation mechanisms would be most effective. And then Kevin Otterson, another keynote speaker at this conference, and myself, we guest edited a special issue in the Journal of Law, Medicine, and Ethics, which was really all about these issues of implementation mechanisms. So there is, and I bring this to show that there's a growing community of people in academia and in government and in private sector who are increasingly thinking about, okay, if we do want to go in this direction to solve this challenge, what would it actually look like? And so just to very briefly, because this is really the focus of the rest of the day, to very briefly highlight is that we do already know the kinds of policies that an international law would need to promote. Some of these are very clear, such as looking at number 10, we need funding for access. Because there's many of the countries in the world are very poor, and people who are who could benefit from antimicrobials are not able to benefit given their cost. This will be increasingly an opportunity for this as most antimicrobials become off patent, and so they can be made generics. They can be produced as generics. But it's still, that will be a main part and a big challenge. Other ones, looking at the top, it's very clear that there is a lot of low-value use of antimicrobials in animals. For example, using them simply for animals to grow faster or grow by means of providing less food. That's a low-value use of an antimicrobial. And then also we have the situation whereby thinking about for future antimicrobials, the ones that are developed that we don't yet have, maybe those should be limited only to humans. Because as much as we could have great stewardship of these products in the agriculture sector, it's probably quite difficult to do that. And if we really have something new, a new last resort antibiotic, maybe we should make sure it's limited. It's making sure that's having an effect on humans. Educating on effective use, infection control practices, and such. In terms of the implementation mechanisms, there's lots of options. I don't think we need every option, but some are quite compelling. So in terms of reforming institutions, one idea would be to set clear milestones in which the world comes together and agrees we're going to do this by this date, and we're going to set up a mechanism to actually monitor our progress on achieving those milestones. What it's doing is it's identifying, like it's facilitating naming and shaming. So countries that are doing well, they get celebrated. Countries that are not doing so well, the data speaks for itself. We can have codes of practice whereby states agree to particular actions in a bit of a stronger way. Interagency task forces, so that chaotic map that I previously showed about the global governance regime is a bit more coordinated. Intergovernmental panels, like we see with the Intergovernmental Panel on Climate Change, to bring together the science and link it to policy. In terms of crafting incentives, we could think of funding agreements, whether it's funding for new research and development or funding for access that might be linked to countries taking serious measures to conserve these products that are provided, for example, for free or subsidized. We could create a global pooled fund to provide either access to research dollars or access to infrastructure supports or medicines. And then conditioning benefits or support. This is maybe the most controversial of these different possibilities. Given what we could do theoretically is condition foreign development assistance on taking steps in this way, which has lots of disadvantages, but it is an option and has some advantages. And then some other ideas would be in terms of mobilizing interests. We can appoint a UN special rapporteur on antimicrobial resistance, a high-level panel, or some sort of multi-stakeholder partnership to really get people's attention on this issue. So it's clear that we need to tackle the biological and clinical manifestations of antimicrobial resistance. That's clear, and that will be subject to lots of discussion today. But it's also clear that if we only look at this issue through a biological or a clinical lens, we're not going to solve it. It's not enough simply to advance our science of the way antimicrobial resistance work. It's not enough to come up with new antimicrobials. It's a biological problem, but it's also a social problem. And a social problem requires social innovation. And it requires, in this case, the need to overcome this political economy of inaction that we're seeing on a global scale. And I personally, and many others, are now starting to think that there is a role for an international treaty to actually protect us and encourage state action around the world in order to promote all of our well-being. And so just to conclude, I want to conclude with some good news, because antimicrobial resistance in many respects is a doom and gloom field, an issue worthy of much greater attention than it's getting, and a lot of barriers and, as I termed it, political economies of inaction. And so I did want to end with the good news. And the good news is that we are starting to see some global action, that if you look over the last couple of years, we have, and maybe a bit longer, we are starting to see really important actors pay attention. One example on the top left is the US-led Global Health Security Agenda. This is an effort that's led by the US. There's a lot of money that's involved, and it's to encourage, now it's up to 60 countries in the world, to take seriously global health security threats, which would include things like antimicrobial resistance, but also things like pandemics. And so that we are starting to see quite a lot of attention on antimicrobial resistance as a result of that, and as well as dollars linked to promoting capacity in some of the poorest countries. On the bottom left, there's this UK Longitude Prize, which is basically, it's a £10 million prize for somebody or a company or whoever is able to come up with a fast point-of-care diagnostic, which means that a clinician in any context would be able to take a sample of the infection and then quickly find out which antibiotic would be most effective for that particular bacteria virus. That kind of diagnostic would be incredible, because it means we can really target in. And if there are any scientists in the room, if you come up with this, it's £10 million. So that's pretty good. And that's led by the UK government. On the top right, you'll see that this past November was the world's first World Antibiotic Awareness Week, which there's lots of people who can be a bit skeptical of UN-led special days, but at the very least, there's this attempt to raise awareness about this issue and highlight that it too, like other diseases and body parts, it too needs key public awareness. And the last this is one that's in the future. We know that in September of this year, the UN General Assembly will be talking about antimicrobial resistance. So who knows what the outcome of that will be, but that's quite serious, that this issue is getting to the highest political forums. So that's positive news. And I just want to end with the local. So locally, we'll hear later today what the Canadian government is doing. We are starting to hear through through colleagues, and we're hearing that things are changing within the government, such that if the Auditor General did their report maybe now, maybe the situation wouldn't be as bad, which is excellent. I won't talk about that because others will. But locally here, even at the University of Ottawa, we're trying to do some action. And so as part of the Global Strategy Lab, we have a global health law clinic, which I know many people in the audience are actually part of. And this clinic, it's a course whereby we pair students with international institutions and Canadian global health organizations to actually work on real challenges that they're facing. And so this year we've partnered with 4 different organizations, 2 of which asked us to focus on antimicrobial resistance. So for example, I know some students in this room are working with the World Health Organization to try to craft, if that organization is asked for an international legal instrument on antimicrobial resistance, what should it look like? So that's a really important piece of the puzzle. WHO is likely to be asked. Our clinic here at the University of Ottawa is trying to provide the first efforts on that, to probably advise WHO on what they should be recommending to member states. And the second, another team of students is working with the Norwegian Institute of Public Health, looking at the political feasibility of any kind of global action. And the idea here is that there is a lot of inaction, there's a lot of political barriers. Maybe we can advise on how to stop it, and on how to address it, or how to bring together a coalition of the willing. So thank you very much. Congratulations to the Ottawa Law Review. And I look forward to today's discussion. Thank you. Merci.
Thank you very much, Dr. Hoffman, for scaring us into attention this morning. Merci beaucoup, Dr. Hoffman. On est maintenant prêt pour la première table ronde de la journée. J'invite nos conférenciers et conférencières de monter sur l'estrade. We're now ready for our first round table of the day on antibiotic resistant and hospital obligations. I'd like to invite our panelists to come up to the stage. And I have the great pleasure of introducing our moderators. J'ai le grand plaisir d'introduire notre modératrice, Madame Nyranne Martin, l'avocate générale à l'hôpital d'Ottawa et professeure adjointe à l'Université d'Ottawa. I have the pleasure of introducing our moderator for this panel, Nyranne Martin, General Counsel at the Ottawa Hospital and adjunct professor at the University of Ottawa.
Bonjour and good morning. I have the privilege of telling you that I'm not Nyranne. My name is David Patrick. I am the Director of the School of Population and Public Health at UBC. And I made the mistake this morning of reminding people that I'm an alumnus of this fine institution. So as a result, as Nyranne was unable to be here this morning, I've been asked to moderate this session. We have 4 speakers who are going to address antibiotic resistance and hospital obligations. Each speaker will have 10 to 15 minutes to talk, and we have a timekeeper here, right? Yeah, so keep an eye on our timekeeper. And we will take some questions after each presentation, and there ought to be some time at the end as well. So without further ado, I'd like to introduce your first speaker. Lorian Hardcastle is an assistant professor and associate director of the Center for Health Law and Policy Ethics here at the U of O. She was a law fellow with the O'Neill Institute for National and Global Health Law at Georgetown University. She completed her law degree with a health law and policy specialization certificate at Dow, and went on to complete her Master of Laws and Doctor of Judicial Science at the University of Toronto. Dr. Hardcastle worked as a senior policy advisor at the Ontario Ministry of Health and Long-Term Care, and her research focuses on health privacy law, health system financing, regulation and governance of the healthcare system, constitutional health law issues, and governmental health sector tort liability. Dr. Hardcastle.
PowerPoint? Is it loaded already, the slides?
We're not sure.
Anybody?
Yeah, the PowerPoint's loaded? Yeah.
Okay, as you can see from that, I am a doctor, but clearly the fake kind, because those are obviously not probably anything even vaguely resembling microbes of any nature, but looks more like a lava lamp. Okay, so because I'm first, and I think some of my fellow panelists are going to talk more about some of the nitty-gritty in terms of cases that have happened in Ontario and some of the more specific reporting obligations that exist. What I wanted to do was just to really kind of set the stage for the sort of ways that the law might get at the issue of antimicrobial resistance in hospital settings. So the different points at which the law might step in to address this problem. So, as you already heard this morning from Stephen, this is clearly a pressing issue, but more specific to the hospital setting. I think some of these quotations and news headings sort of illustrate kind of how pressing this is within hospitals, more specifically. So, to give you an idea of sort of why it's so important in the hospital setting, we have a combination, of course, of very sick people. And then intensive antibiotic use. So the kinds of concerns that might exist in an outpatient setting are amplified within hospitals. And some of the estimates are that the cost of just one antibiotic-resistant infection in hospitals, MRSA, are between $42 and $59 million in Canada a year. So those are the costs. Some U.S. studies have tried to kind of come up with a per-patient cost and have found that it costs about $30,000 more to treat a patient who develops some sort of antibiotic-resistant infection in hospitals. And then in terms of sort of mortality, the estimate is that between 8,000 and 12,000 Canadians die in hospitals from hospital-acquired infections. So clearly the scope of this problem in hospitals is very important. So a couple of different ways that we might get at this problem. The first are hospital infection control standards. So hospitals have a variety of policies in place relating to infection control. So things like sterilizing rooms, sterilizing equipment, all of that sort of stuff. And the reason that this kind of feeds into the problem of antibiotic resistance is because, if we have an unclean environment, it contributes to the spread of organisms which may ultimately be resistant to antibiotics. But also, the more sort of prevalent infection is, the more prevalent antibiotic use has to be. So that's one kind of domain where the law might address the issue. And then the other, of course, is inappropriate antibiotic use. So the estimates that I've seen are that half of Canadians, half of antibiotic prescriptions in Canada are unnecessary. One international study kind of specific to the hospital setting found that 70% of ICU patients were receiving antibiotics, and about a third of that was unnecessary. Oh, and I advanced this slide without even knowing. So that's another kind of domain where the law might step in. And so, kind of more specifically, what kind of legal instruments are we talking about? And the first might be to target inputs. So how can we proactively, before any sort of antibiotic resistance occurs or unnecessary use of antibiotics occurs, what kinds of laws or policies can we put in place proactively to target sort of inputs? And that could be at the hospital level, and I'll talk more specifically about some of the kinds of laws I'm talking about later. But it could also be doctors working within hospitals. So this is more sort of proactive. But then, of course, the law can be reactive, right? So once there's a problem that's been identified, either with, say, a particular hospital or a particular doctor's prescribing, how might the law step in there? And so, ideally, though, of course, we don't just want to sort of sanction or be reactive. Ideally, however we're reacting to bad outputs, we're reacting in a way that sort of feeds back in to being proactive. So, for example, if there's a hospital that has been sued for its infection control, ideally we don't just want that to be a sanction, but we want there to be deterrence, and for whatever lax infection control processes existed in the first place to then kind of feed back and in theory for that hospital and other hospitals to learn from that. And similarly, if let's say we were to develop some sort of law to sanction inappropriate antibiotic use, again, we wouldn't just want that to be a sanction, but to feed back in and sort of deter other providers from prescribing in that way. So to start then with output regulation, I think when we think about well, I've been infected in a hospital. What is my recourse? I think that tort liability is one place that the mind naturally goes, and one of our other panelists is going to be talking about some of the specific kinds of claims that have happened in Ontario. But because we have a non-legal, there's definitely some non-legal folks in the audience, I just wanted to sort of briefly go over what is required for a negligence claim, and then more specifically, some of the kinds of barriers that might exist in terms of suing either a doctor or a hospital for contracting an infection while in hospital. So the first requirement for a negligence claim is that there's some sort of duty of care or some sort of threshold of a legal obligation, and that clearly exists both between doctor-patient and hospital-patient. So that's not a sort of significant barrier to a legal claim. The next requirement, though, is that there has to be some sort of breach of a legal obligation. And so the case I have up there, Bruce Estate, was a case where a man contracted MRSA during spinal surgery in a hospital, and it was an attempt at a class action against the facility. It's fairly clear that the facility did have some issues with its infection control. But because it was only a preliminary sort of hearing, we don't get to know what happened to the case on its merits. But we do know that the court said that hospitals do have duties to establish appropriate systems and protocols to promote patient safety and provide good patient care, to protect patients from infection, and to ensure that infection control processes are followed. So there is this threshold obligation that both hospitals and doctors would have to act reasonably in terms of infection control. But that's only one requirement for a negligence claim. Another is that there's an actual sort of injury. And so as one of my co-panelists is going to talk about a little bit later, there aren't a lot of Canadian cases where there has been an actual kind of physical injury where a patient did contract an infection and kind of tied it back to the hospital. And so as she'll discuss, there are some limits on the ability to collect damages for mere psychological injuries in this context. But I think one of the biggest barriers to tort liability as a way of getting at this problem is the final requirement for a successful tort claim, which is causation. So the plaintiff has to actually be able to show that whatever the defendant did that breached the duty of care was the cause of that injury. Now, it doesn't need to be the only cause of the infection, but it has to be a cause. And so, you could imagine for a variety of reasons that it would be very difficult to show that a particular doctor's or nurse's or whoever's action was the cause of your injury, because a variety of different a variety of different sources can lead to an infection within hospitals, right? Infections may occur naturally. Infections may be brought in by visitors, and so its causation can be difficult in these cases. So the case I have up there was, again, a case where there was an infection contracted, and it was in the course of a C-section and then post-operative care. And this woman contracted the flesh-eating disease. And, the court, though, as you can see from that passage, struggles with, well, how did this infection happen? Like, what is the timing of this infection? Was it linked to, did it happen when the doctor was negligent? Did this patient already have this infection, et cetera? And so the causation question can be a difficult one. More broadly, though, I think one of the issues with negligence as a sort of response to this problem is that it's imprecise. Very few negligently injured patients actually sue hospitals or doctors. Very few of those claims are actually successful. And so there's probably limited kind of scope there for kind of using that to deter inappropriate sort of prescribing or infection control. Other ways that we might get at these problems in terms of output are, of course, professional discipline, which largely would sort of mirror what we're talking about in the negligence context. But also, some other jurisdictions use financial sanctions. So the Centers for Medicare and Medicaid in the U.S. don't reimburse hospitals for the costs associated with never events, which include a variety of hospital infections. And then, of course, reporting, which I think you're probably going to hear a lot about today, and you've already heard a little bit about. But that's another kind of important piece of looking at the outputs. So once infections have happened, how are those reported comprehensively? How is that data shared, et cetera? And so I think the suggestion was made a little bit earlier that Canada is starting to take action on this. But certainly there are several European countries that are much further along, and some of them are actually contemplating mandatory reporting to government when a first sort of instance of antibiotic resistance is identified. So that information doesn't just stay within the hospital, but is sort of immediately shared. And so in addition to regulating sort of the outputs, we can also, as I said earlier, be proactive and attempt to pass laws that get at the problem before it happens. And so one of the reforms that's being discussed sort of around the world are stewardship policies. So this is hospital policies that relate to appropriate antibiotic use. Only a handful of Canadian hospitals have these in place. But the data is promising with these programs in which antibiotic use is tracked, and there's often a computer to give sort of feedback on the antibiotic that's being prescribed. And so the studies in Ontario have shown that with a stewardship program in place, appropriate antibiotic use jumps to 80% as compared to 50% where there's no such program in place. And so California is the only state, and that's done this, but they've actually gone ahead and made it a statutory requirement that there's such a stewardship program in place. And so, you can see that they're required to have a policy in place. There has to be a physician or a pharmacist supervising a committee that deals with antimicrobial stewardship. And then all of this data that this committee collects gets reported to hospital quality committees. And interestingly, the situation in Ontario, in California, there was a interview with a couple of different hospital pharmacists kind of explaining how it worked in their hospital. And one of the pharmacists explained that what happens is the doctor sees, does all drug entries happen by a computer? The doctor sees the computerized, puts the condition in, gets a drop-down menu of suggested antibiotics, and then if one of those isn't picked, the hospital pharmacist says that she actually goes and chases down the doctor and tries to convince the doctor otherwise. And some California hospitals in implementing this law have gone even further in terms of responsible antibiotic use. And some of them, what they've done is, again, required that all antibiotics be done by computerized entry. But if a restricted antibiotic is going to be prescribed, it's actually, the pharmacist actually can't dispense it from the hospital formulary until a doctor who's sort of appointed as the on-call member of the antibiotic committee has a consult with that doctor. And if that doctor apparently repeatedly persists in prescribing antibiotics that the committee feels shouldn't be prescribed, that matter actually goes to a hospital peer review process. So some hospitals in California have sort of taken that legal requirement and really come down quite hard on inappropriate prescribing. Potentially that kind of law might be useful for Canada, where the uptake of these stewardship programs is quite low. Accreditation Canada, who accredits hospitals, has apparently now made this one of their accreditation standards, that hospitals have to have a stewardship program. But apparently, only half of hospitals surveyed a year after that standard came into place have gone ahead and done it. And apparently funding is also a major barrier to that. And so, those are certainly areas where when we get into the discussions later on kind of the actions that government may take, those are some of the things that they may consider at the hospital level. And so finally, prescribing, restrictions on prescribing, limits on prescribing. There's been some studies that have tried to correlate how sort of strict guidelines on health professions are with antibiotic use, and the Netherlands is often given as an example of a jurisdiction that has done the most to attempt to produce guidelines and dispense them to physicians and sort of pressure physicians to use them. And apparently they have some of the lowest rates of antibiotic prescription. So that's another area to target. So I will conclude there because I'm getting the please be quiet look. But I'm happy to discuss any of this further during the questions.
Thank you, Dr. Hardcastle. And on the subject of real doctor, remember yours is a graduate degree, and that's pretty important. We have time for maybe one or two questions while Dr. Connolly's slides are put up. And my question for you is this. It was interesting seeing you think about tort law and so forth. I've been working with dentists lately. A lot of them are vastly overprescribing against their guidelines, and they cite fear of civil liability as the main reason for doing that. How can law help?
Yeah. Well, I guess, there always is this sort of fear of liability, but it really is more kind of theoretical than actual.
Yeah.
We don't have good numbers against other health professions, but certainly with respect to doctors, it just doesn't play out that very many negligently injured patients sue, or that very many claims are successful. And some of the reasons are, I think in the cases where they're clearly disregarding guidelines, I think that you could prove sort of that breach of the standard of care. But it's often difficult to prove the causation piece, because so many infections and whatnot are naturally occurring. And in addition, another barrier in the sort of dental context is it's often hard to find a lawyer to take a low-value tort claim. And so, in the dental context where your injury might be sort of a kind of infection or whatever the case may be, the kind of damages are fairly limited. So dentists really don't have too much to fear in terms of tort liability.
I'll pass that on to them. John, a question from you before we get you.
Just a brief comment about the Accreditation Canada and the required organizational practice, the so-called ROP standard. You mentioned the survey only 50%. I think that's going to change. You have to recall that the accreditation standards, they rotate from hospital to hospital. They have a 3 or 4 year accreditation. it's very embarrassing if your hospital can't put the plaque up that you passed accreditation because you failed stewardship. Yeah. And what I'm finding is that as the date approaches for their accreditation, because the year has come up, suddenly there's a mad scramble to get the stewardship programs in place. And so although there are funding issues, that is a major driver. You might call it the embarrassment factor. Yeah. And so if you surveyed in another 2 or 3 years or after a 4-year cycle since that first came in 2014, I believe, I think you'll see a lot more activity occurring.
Yeah, I guess the concern with kind of just doing it sort of under the wire just to meet the accreditation standard is I guess the robustness of the program, and so we certainly wouldn't expect a program as robust as some of the ones that we're seeing in California, where there are these kind of very real concrete processes and procedures in place, in some of the pharmacists that they had talked to, hospital pharmacists, said that sort of California's law reforms, some of them were just kind of saying to the pharmacist, you are the program, so just monitor this and think about it. So I guess that would be my only concern there is the robustness of it.
Yeah. With that, I'm going to introduce Dr. Connolly more formally. John is a good friend and colleague, a professor at the University of Calgary. John has been a chair of the Department of Medicine there. He's been head of our Canadian Infectious Disease Society. He's editor-in-chief of the Canadian Journal of Infectious Diseases and Medical Microbiology. You were complaining that your feet were wet this morning, John, because you had to leave your horse at the road. But anyway, John has been one of the long-term voices in the wilderness on this issue. He's been giving visibility to it since the early 90s, at least, and he's been involved in initiating efforts in hospital epidemiology and the Canadian nosocomial infection surveillance program. So it's good to get the long view on hospital control from John Connolly.
Thanks very much. I did park my cowboy hat outside, so it's a pleasure to be here and to address this topic. It's one that's near and dear to my heart. I've been at this, as Dr. Patrick has mentioned, for many years, and I was the president of the Canadian Infectious Disease Society in 1997 when the original consensus conference on AMR was held in Montreal. Which is forward button? Thank you. My disclosures, both industry and academic, listed here, but notably I am on the WHO AGISAR group. I saw that on the previous slide from Stephen Hoffman, and I'll address that in my talk this afternoon with respect to the international health regulations at a later date. So just some objectives. I'm going to look at some background about acts and standards relevant to antimicrobial resistance, describe where AMR fits within the public health acts, other acts and infection control standards, and then outline the liabilities with respect to AMR at the hospital level. So from a national process, and I'll start there, we have federal and pan-Canadian framework from 2014 to 2015, again, not legally binding. It's a framework for action, but for the first time in many years, we're seeing a lot of parties come together that had not come together previously. We have the WHO World Health Organization and the fact that by May of 2017, Canada is one of the member states who signed on to that statement with the World Health Assembly in 2015. We have to have our act together, so to speak, by May of 2017. Again, not legally binding. And then we have the Accreditation Canada standards that are used to assess governance, risk management, leadership, and infection control. Not legally binding, but there is a significant moral and ethical responsibility, and as I mentioned, an embarrassment factor, because no one likes to go into their hospital and the sign they prominently display, "We are fully accredited until 2019," is removed, and then you start asking, "Oh, we failed stewardship, so as a result, we don't get it." That has a significant concern to individuals who will go to that hospital, but again, not legally binding. And then With respect to infection control, we've got the Public Health Agency of Canada with the nosocomial infection surveillance program, and they post trends for hospital-associated infections and things like MRSA and VRE and others, but it is, again, only done on a voluntary basis by participating hospitals. This is the Chief Public Health Officer's report on the state of public health in Canada in 2013, and you can see that they discuss issues about Clostridium difficile. It's tripled the number of methicillin-resistant Staph aureus infections. At least it's made available publicly, but again, this is not legally binding. It talks about good hygiene and best practices. So from a national perspective, we have only those issues. And I'll speak about Alberta since I know it best. These are the health regulations in Alberta, not dissimilar to many provinces, I suspect. And we have 30 laws and 100 schedules of regulations, rules, standards, and bylaws with respect to healthcare. And relevant to antibiotic resistance, we have the Public Health Act, the Regional Health Authorities Act, and the Hospital Act. I'll dispense with the Hospital Act because there's really nothing but a very oblique reference. So really, for all intents and purposes, it's not concerning. Then we have standards for infection prevention and control, which is more about accountability and reporting. But I will address some issues. So here's our Public Health Act, 1985. It's still sadly out of date, as are many of them, but there are more pressing issues economically, so I doubt that we're going to see any reform in the Public Health Act, although every time I talk to the public health officers and officials in the Ministry of Health, oh yes, that act, we need to get rid of it. And I think I have a slide that may show you something. In the Public Health Act, they talk about the medical officer of health will investigate occurrences of notifiable diseases. Those notifiable diseases in a list may include antibiotic-resistant organisms, and if you have individuals that have MRSA or a carbapenemase-producing organism, it is notifiable, and if you get them spreading throughout a hospital institution, the medical health officer is obligated to investigate. So that is actually within the Act to allow that to occur. And then they talk about the medical officer of health taking all reasonable steps to ensure the provisions of this schedule with respect to the control using of the infection, the isolation precautions, and of course quarantine. And just to show you how out of date it is, I'll draw your attention to the bottom of this slide, that in terms of the schedule and the strict isolation, it goes and talks about contact and airborne. You need to protect individuals who are caring for the infected person. But then to show you how archaic, I think this comes from the last century, the infected person shall have a bed in a separate room protected against flies. So that just goes to show you that it's probably language in the Public Health Act from the late 1800s, early 1900s that's brought forward, and why this Public Health Act and probably many provinces are out of date, and it just doesn't hit the priority list with all the other issues the government has to deal with. But it just goes to show you that there are some issues in public health acts that are out of date. So this gives you an idea of the surveillance list, and so you see things like anthrax, syphilis, diphtheria, which we don't see, gonorrhea, and a number of rabies, bubonic plague, MERS, coronavirus from the Middle East. So these are a number of diseases or infections that can occur. But then they have a second list, and on this second list, I'll draw your attention. I think there's a pointer here. Anyway, I've put it in the red boxes. So within the notifiable surveillance list, so this is laboratory detected MRSA is present. The carbapenemase-resistant organisms are present. Those are the New Delhi associated superbugs that came from India, the metallo-beta-lactamase-producing organisms. And then you'll also see MRSA. Missing is VRE and some others, but there are 3 in our province that are listed as notifiable, so that if there were an outbreak or spread, then they're notifiable, and it, within the context of the Public Health Act, allows the medical officer of health to engage in investigations and control measures. So that is within the context of the Public Health Act. And that is the most direct that you'll find within the Health Authorities Act. There are regulations that suggest you have to promote and protect the protect and promote the health of the population in the health region, prevention of disease and injury, and that they have final authority in the health region with respect to matters related to this in Clause A. So you can use this as an oblique reference that if you had an antibiotic-resistant organism that was plaguing your population, you then, under the Regional Authorities Act, can go to look at protecting the health of that population who are affected or those that might be at risk of being affected. So that's, again, a reference to this within the Regional Health Authorities Act, which you could look back at the Public Health Act to be able to look at enacting that. So when we come back to issues of standards, and this is probably where the tire rubber hits the road, so to speak. This is where you've got the purpose of standards, and I think our previous speaker mentioned standards in Ontario. Most provinces have some type of infection control standards, and this is all about accountability and reporting. It promotes clarity with regards to the roles and responsibilities, and then looks at documents that apply to IPC matters, but nothing in this or any of the other standards fetters the authority and responsibilities of the Chief Medical Officer. So within the context of the Public Health Act, the Chief Medical Officer has the final trump card in that respect. But usually they work fairly closely with the individuals in the hospital institution. And within the infection control programs, there's a province-wide system with standards. We have standards for MRSA, which they just redid, looking at screening all individuals coming from long-term care facilities into the hospital environment, and they've just now canceled that as there have been some work that's gone on in this. They talk about IPC activities, the monitoring, and there is a compliance unit in the province of Alberta to ensure that the standards are complied with. But again, they do that on a rotating basis. And then if there's non-compliance, it will be promptly investigated and addressed, and individuals working on behalf of the Regional Health Authority, now known as an AHS, receive up-to-date training in IPC practices. That is woefully inadequate, but it is there in writing. And we also talk about the reporting requirements. There's not applicable except in the case of outbreaks. So if you have an outbreak of an antibiotic-resistant organism or C. difficile, it has to be looked at, and there is often public reporting of this, and the health authority does post its rates of C. difficile, hand washing, and other things. Now, there's another session you could do on the gaming of the system in that respect, but that's another topic for another year, I guess. And then also investigation of contacts. Again, the medical officer of health is engaged with this. And again, the medical officer of health looms large within the Public Health Act and the Regional Health Authorities Act to be able to have the authority to be able to move this. So that's the way that the law works within the statutes that are written in the province of Alberta, and I suspect in many other provinces as well. So in summary, there are no direct references to AMR with respect to legally binding components other than the notifiable diseases, because it is in the notifiable diseases. If there were an outbreak, then action has to be taken. And if you were to take it to the full extent of the law, you have the legal ability to be able to move on that. But generally, it does occur if you do have an outbreak. There is no direct legislation referring to AMR that I could find in the province of Alberta, and I suspect other provinces. I just didn't want to do all other provinces and territories too much work. And our Public Health Act in Alberta is old, and certainly some components are out of date, such as having rooms that are not infested with flies. And it's something that should be put on the front burner to be able to allow an updating of the Public Health Act, even if it gets started. So if there are any of you who are looking for a career in Public Health Act legislation reform, there are many opportunities. Thank you.
we have time for some questions for Dr. Conley. John, while we're waiting, we saw a rewrite of the Public Health Act in BC, and there's a clause in there which means that you don't have to go back to Cabinet every time you need to add something to the list. It can be at the discretion of the Chief Medical Health Officer if something is epidemic, so it allows fluidity. Is that a common clause? Is it a clause in Alberta? Is it common to other acts?
Yes, thank you. Great question. And we do have that degree of fluidity so that you can add. So, for example, carbapenemase-resistant organisms were not present previously. So it does have a clause that allows you to be able to add as the need arises. So some components of it have been updated so that they were able to do that. But as I showed you, there are other statements that are a little bit archaic related to flies and other items. I think they call it public health nuisance, which is very ill-defined. So some components have been updated, but others have been left with the archaic language. So there is still a need for reform.
Dr. Willett.
Yeah, so exactly what you said. You put MERS, Ebola, when I know that you have a lot of vision in Alberta, but probably in '85 you were not expecting that. But for the flies, maybe you were expecting Zika, and maybe that could be of it.
Okay, that's a good point. And for the record, I would say that Zika is very closely related to West Nile virus. So although they say we don't have the right mosquitoes, they said that about West Nile, and the mosquitoes in Western Canada are mostly Culex. So I'll be interested to see if the entomologists are correct about whether it's going to spread into Canada. I suspect it will, actually.
I was going to say wrong flies, but John and I are going to have to arm wrestle about this one later on. Are there any other questions? Okay, we'll get on with our next speaker. I'm now going to introduce Kim Dullet, who's an associate with BLG, Borden Ladner Gervais, LLP in Ottawa. She received her LLB from this university in 2008, called to the bar the following year. Ms. Dullet practices civil litigation with an emphasis on complex commercial disputes, insurance litigation, and the health sector. She regularly represents clients before various courts and tribunals, including the Superior Court of Justice, Divisional Court, Ontario Energy Board, Health Professions Appeal and Review Board, and Consent and Capacity Board. Ms. Dullet frequently contributes to the Law of Privacy in Canada blog, which would be of interest to those interested in matters related to current privacy issues. But today, she's talking about antibiotic resistance.
Thank you very much. I'll remain seated. My present condition is a little bit easier for me, and I don't have my slides with me. My practice on a day-to-day basis focuses on the health sector, and in particular litigation in the health sector. So on a day-to-day basis, we deal with medical malpractice claims as against the hospital and nurses. That's the primary entities that I defend on behalf of the insurer that we work with. So I'll speak from that point of view with respect to defense of the hospitals with respect to tort claims. As Dr. Hardcastle pointed out, there is not a lot of case law with respect to superbugs and antibiotic resistance at this point in time. But there are other cases out there with respect to infection control that have developed in the last decade or so. So we do have some point of reference. Now, on a day-to-day basis, when a hospital becomes aware of an infection control issue, there are certain steps that are taken, and taken very promptly in my experience. The hospital will look to see what the source of the infection was, and it could be the identification of what we call an index patient, so a patient that has presented with an infection, with an active infection, and trying to isolate any sort of the source of that infection and any other patients that could have been exposed. Or it can also be in the context of an internal audit that's done on a periodic basis with respect to sterilization procedures of instruments and whether they meet the standard. So when an issue is identified, the hospital will come back to its legal team and consult with us to draft a notice to affected patients or potentially affected patients. So we'll assist the hospital in identifying the appropriate group of patients and then drafting the notice that goes out to them. The notice itself will usually advise the patient that there's potential exposure. It'll identify if it's a small risk, if there's a substantial risk, and provide any sort of testing that should be done and recommend any sort of follow-up. Now, receiving that sort of notice can obviously be a very stressful experience. You've attended at the hospital, it may be for any number of reasons, and now you've potentially been exposed to an infectious issue. And there's nothing to prevent the patient from going to the media, which often occurs, going straight to the newspaper and saying, this is what I got in the mail, and then from that sort of exposure, plaintiff's personal injury counsel, so a counsel that certifies class actions, could get wind of that and then put out their own advertisement saying, anybody that's received this letter, come and see me, we're going to go forward with a class action. And it was our experience that more or less whenever a letter of this nature went out, invariably there would be some sort of litigation that was commenced, or the steps were taken to try to commence this sort of litigation. That's changed recently in the last last 5 or 6 years. As late as 2009, there was a case, the Farkas and Sunnybrook Health matter, in which so I'll talk about the case and then some of the developments in the last couple of years. So in 2009, there was an there's an internal audit that was done at the hospital, and it was discovered that the disinfecting procedures of some of the urology clinics' instruments was improper. Notices went out to about 913 patients telling them that there was a very small risk of infection. Years go by, testing was done, and it turned out that only one patient contracted a virus that could have been linked to the use of this equipment, but the causal connection just wasn't clear. Notwithstanding the fact that there wasn't any actual infection other than this one case, and again, it wasn't causally clearly connected. In this case, the hospital and class counsel did reach a settlement, and that was to the tune of about $739,000, so relatively modest given the number of people that were in the class. And that was, and then the court approved this settlement. The court approved it because it was in the interest of all parties to resolve it, not go forward with the pending summary judgment motion that the hospital had brought, and subsequent litigation. So that settlement was reached. If we go forward 2 years, a very significant decision from our perspective, that's the Healy and Lakeridge Health decision. That's a 2011 Ontario Court of Appeal case. In that case, there were 2 patients at the hospital that were identified and diagnosed to have active TB infections. The hospital then went and notified the regional health department and notified a class of individuals that they had a potential risk of TB infection and advised them to get tested. This resulted in class action litigation. And on appeal were only those patients that didn't actually suffer any sort of infection. They brought their claim purely because of the psychological distress that they say that they suffered getting this notice in the mail. So the hospital brings a summary judgment motion stating that there wasn't any compensable harm to those individuals that claimed that they only suffered psychological stress and anxiety. And the motion judge agreed with the hospital. So the class action was thrown out, essentially, that because of the fact there wasn't any sort of injury, that there wasn't any sort of compensable damages. Now, on appeal, the appellants appealed, and on appeal, the central issue was whether the harm the class members alleged that they suffered actually gave rise to a claim that was compensable in damages. And the court held that the hospital does have a duty to prevent psychological injury to its patients, but it's laid out the test for a psychological injury. So there has to be a diagnosed psychiatric illness that results from this stress of getting the letter. So it can't just be anxiety and stress associated with it. Was there actually a psychiatric illness that was diagnosed? So again, the appeal was dismissed for those reasons. There is a duty on the part of the hospital to prevent or not cause psychological harm, but again, it has to be a psychiatric illness. When this decision came out in 2011, we actually had several active class action lawsuits on the go where there was no actual injury or an actual contraction of an infection, but they were certified because of the fact of this psychological stress. And we were able to get those decertified on consent because following with this decision, unless any of those patients actually had a psychiatric injury, so psychiatric breakdown, any sort of issues that prevented them from working or functioning, unless that sort of issue was part of the lawsuit, this decision gave us the authority to go ahead and take steps to decertify those. So that was a very helpful decision. So taking it back to our discussion today, when it comes to superbug infections and how that's going to play out, from our perspective, it's a wait-and-see sort of approach. As Dr. Hardcastle pointed out, the toughest connection with these types of cases is going to be the causal link. If there was an infection that was contracted and there was a breach in the duty and the standard of care, at the end of the day, is that an infection that could have been caught elsewhere? Would different care and management have prevented that infection? So those are the type of issues that we'll be grappling with going forward. That's what I have today. Yeah.
Very interesting. We have some questions on this discussion. Dr.
Actually,
Willett.
to the two lawyers, I've heard that there's very little or complicated litigation, but what about in the South where there's much more suing? Were there any cause related to contractions of AMR organisms, antibiotic-resistant organisms, or it's more malpractice or?
For cases in the U.S.?
Yes.
So there have been some cases in the U.S. That didn't specifically relate to sort of superbugs per se, but there are a bunch of cases where patients were infected, a variety of different kinds of infections during care, and so there have certainly been judgments there. There was a case in Missouri. I'm not sure what the exact injury was, but it was in putting in a pacemaker. The plaintiff contracted an infection, and he was given, I think, $7.5 million. And that was actually brought down because there was a cap in the state on damages, so the jury had awarded more. And I think maybe the higher prevalence of jury trials there might lead to more successful claims there. There are a handful of other U.S. cases, too, where the causal link is much more clear. So, for example, there's a case, and the name eludes me, but the state eludes me, but it was a case in which the plaintiff contracted herpes in the hospital, and it was like the patient in the next bed had it, and there were concerns about the nurses and all this washing the hands and all this other stuff. And so I think it's easier to maybe establish a causal link when it's not just an infection that's sort of in the hospital and you might get any variety of ways. In that case, that kind of particular infection was linked. But so there are some U.S. cases relating to sort of infections, but I'm not sure that I've encountered one where it was for psychological injuries and not an actual infection. Maybe do you know of any?
Yeah. Well, along the same lines, maybe following up on some of the things that we were talking about before, that as a physician, you only know so much about how the law goes down, but we were taught that when we practice according to evidence-based guidelines and we're following a guideline, usually that insulates you to a large degree against liability related to the care involved. Is that clearly true? Because if so, I think maybe we need to write an article for the dentists about this together.
So what by guideline do you mean like the colleges come out with guidelines and this is the way that you're supposed to practice? Well, the guidelines certainly set the standard of care that's applicable in the circumstances, and that's the legal test that we use for medical malpractice claims. What a reasonable physician in similar circumstances, and we look at, is it a tertiary care center, is it a rural center, what type of practice there is. So in those circumstances, would the reasonable physician have done the same? And the guidelines do speak to that, so a lot of times there will be a reference to the CPSO or whatever it may be, or typically in most medical malpractice litigation, what we do is we retain an expert of the similar sort of circumstances as the physician that's named in the litigation to speak to whether a standard was breached. So it'd be your colleagues, it'd be your guidelines, and if you're practicing within that, again, you are insulated. You should be insulated, but there can be debate as to what the standard would be. So.
Yeah. Just to add, I think there's been and you've probably seen the same thing. There's been a trend. I mean, defining the standard of care really used to just be sort of a battle of the experts, but with the rise in evidence-based medicine and guidelines, I think more and more decisions the judge will actually make reference to sort of professional guidelines, and so I think it does seem to be becoming more and more relevant in setting the standard.
Question here. Can you? There's a microphone coming to you.
Okay. So how does that come into play when professional standards disagree with one another? Because in general, they are evidence-based, but with reference to the dentist, they may be operating on different clinical guidelines than clinicians who prescribe many of the same substances. Has there been a legal context in which that has been a part of the discussion?
Just while you guys are gearing up for this, the specific examples we're looking at, we've actually seen that while doctors are prescribing fewer antibiotics, dentists are prescribing way more. And when you ask them, it's often to give them antibiotic coverage for an operation in case there's a complication where bacteria get into the bloodstream and cause something else. But the thing is that the guidelines have actually said, the evidence isn't very good for this in most cases. You can actually cut down on it quite a bit. But most of the dentists haven't followed the guidelines because they are still concerned about liability from the odd case of endocarditis or something coming along. So it's not really so much a question in that instance of which guidelines are valid. These are valid throughout North America and Europe and so forth, but whether they feel insulated. But the question here is really when you have competing guidelines, how do you get those resolved? Sorry?
Yeah. Oh, yes.
I mean, I don't think I've encountered competing guidelines per se. I mean, the guidelines are, the guidelines that I refer to on a daily basis would be the College of Physicians of Ontario. So, they have set guidelines there. It's not necessarily conflicting. So, I don't think I could really speak to that.
No, I haven't seen that. I've seen competing experts happens all the time, but not usually so much with the guidelines.
And when you have competing experts, the way it plays out at trial is that the judge then plays the role of the trier of fact. So you look at the credibility of the experts. Have they given prior testimony? What is their academic credentials? What is their clinical credentials? And so it turns into an exercise of weighing which expert will be more credible at trial. And when we look at that very carefully when we retain our experts, also for that reason, for the credibility piece, because unfortunately it is relatively easy for counsel on both sides to get someone to provide the opinion that they want. So the issue is the quality of the opinion at the end of the day.
Thank you.
One question.
Okay, well, the question from Dr. Conley.
So just a question on the Lake Ridge case study that you presented. With the tuberculosis, the plaintiffs argued about psychological distress, but what about the two individuals to whom the tuberculosis was actually transmitted? did they actually launch any suits against the hospital for lack of identification and then actually contracting tuberculosis, or no?
So the class action was, there were subclasses to it. So there is the infected parties were one class, and then those that claimed that there was a psychological injury were another class. So the psychological injury class was decertified, and it's my understanding that there was a settlement for the patients that were actually, but I don't have that information. I think it was out of court.
Because I would have thought that that was
compensable.
Yes. Compensable, absolutely. And that if there was not due care and attention, and then obviously unidentified and misdiagnosed tuberculosis, they may have a case to make.
Yes, absolutely.
So at this stage, it's a pleasure to introduce our final panelist, Dr. Patricia Horsham. She hearkens from the Children's Hospital of Eastern Ontario. It's a really cool facility. I did my peds there some years ago, and she is a double threat. She's trained in both medicine and law, so she's had to deal with the jokes aimed at both professions throughout her career. What else can I tell you? After obtaining law, she began doing a lot of work as an expert witness in child abuse cases in Canada and the U.S., this developed into an expertise where she's become a published author, both books and journals. And more recently, she's published a book on her work with medical evidence used in child abuse cases. Her professional involvement in both medicine and law include numerous appointments. Dr. Horsham was appointed to the U of O's representative to the College of Physicians and Surgeons of Ontario and acted as physician's representative for this institution. Dr. Horsham has lectured to members of the U of O's Faculty of Law as well as to medical professionals, and she is an honorary patron of the Ottawa Law Review.
How many hours do you have? What you forgot to add is that, yes, I have been sued. That was the final bottom line. I had a medical legal case against me. And again, it was a battle of experts. And I was looking on. What caused me not to have PTSD is because I had legal knowledge, okay? So I was able to look on and to tell off this lawyer and tell off that lawyer and what have you. And eventually the case was settled out of court because there are two battle of experts, which the case took 10 years. The battle of experts, which would have taken another 10 years, and I could see both sides. Come on, to talk? Okay. I could see both sides' argument, and they didn't listen to me, of course. You know, you're just a doctor. And I think they had to settle the case out of court, just pay off the parents, and then from the CMP point of view, their practice in-house, they had, I think they told me for insurance purposes to put the blame on somebody. They couldn't just leave it wide open. So as I was the older physician, and there was a young physician just starting her practice, I was told even long before we had the case that I was the one going to be found liable because I'm nearly finished practicing, and this new lawyer, this new doctor didn't want to have this hanging over her for the rest of her many professional lives. So that was a decision, but I didn't have anything documented against me as being guilty of malpractice on my CV or anything. It was just an in-house decision. Okay? Okay. I don't know where to start. I think what happened is we dealt a lot. I think the superbugs, I wouldn't bother to use my slides because it is sort of complex. But I'll mention a few things in regard to some of the questions and the comments that have been made. First to begin, yes, you got superbugs, but nobody attended to hospital liability. And the hospital liability is really, the hospital is a very, very complex situation. Actually, I worked for 30-something years in emergency department of CHIO. And work in emergency department, after being there for 10 years, to be able to sleep at night, because every time you go to do something that is a threat, oh my God, you're going to get sued. So I decided, you know something, I'm going to do a law degree. So doing the law degree helped me to deal, at least on a fun basis, with the possibility of being sued and what have you. And then, of course, I got appointed to the college, et cetera, et cetera. And the more law you know and many more things I did, I put myself up and I was attacked more from my colleagues. You know, they report me here, they report me, they report me everywhere. They don't like lawyers, so I I got it in the neck. Okay, so a few comments I'll make about hospital liability. It's a very, very complex culture within the hospital. You're working in groups. You don't have to check on the nurse. You tell the nurse, would you do X, Y, and Z, take a swab. There's an assumption that the nurse has been trained, that she's meeting a standard of care. She's been employed by the hospital. So you just hand out. And the Regulated Health Professional Act gives the physician the privilege to be able to delegate tasks. So you delegate tasks to a nurse, and you just assume that she knows what she's doing, okay? And then you carry through. You can't check everybody's credential and say, well, I wonder if you understand what the word means. And therefore, it's on nurses, the nurse or whoever you delegate the task to say, I don't know what to do. I don't know how to do it, okay? Now, again, you've got junior doctors who comes out of medical school and they have the God complex. So they don't want to say, I'm sorry, I don't know. They sort of fuddle through. And they're quite shocked when I turn and tell the patient, look, darling, I don't know what that rash is, you know. You can't tell the patient, you don't know, you're supposed to. I say, no, I don't know what the rash is, but I'm able to tell you what the dangerous rashes look like. So if I tell you what the dangerous rashes look like, I'll know if to admit the patient or send the patient home, and then we can see what else happens. So knowing law gives me a very comfortable way of dealing with the situation. So in the hospital, for example, there's a case at one of the better known hospitals where you've got a change in the hierarchy, and then they appointed some senior nurse to look after infectious diseases. So this senior nurse found out there was a patient seen in emergency who had quote-unquote measles, and oh my God, it's 7-10 days after the measles was diagnosed in emergency. So she hopped down to emergency, closed down all the rooms that the patient had been in, sent home the staff and say, you've been in contact, you have to wait to see if you get measles. And it created great chaos in the emergency department. So you have to really check that the people you're putting in charge really are qualified to carry out certain guidelines and what have you, and know what they're doing, and also has the personal integrity to say, darling, I don't know, you better ask somebody else. I went into a coroner's inquest where a patient died, and again, that shows you how many factors come into hospital liability. This was a case where physicians, all the surgeons had gone to Montreal to attend a conference, and they left this one surgeon to do the OR list for that day, and everything was fine. They had protocols, again, protocols and guidelines. You have to double check sometimes, but protocols and guidelines tend to sometimes give anybody, any professional, a feeling of comfort, oh, this has been tried many times, nothing can happen, okay? And that it happened that day, that the physician who was doing the list was fairly relatively new in the area. He did the list, he did his job fine, and he sent his patient to this recovery area to be recovered. But he didn't know then that the hospital had cutbacks. So the hospital had fired all their senior staff, all the senior nurses, and they hired a new lot of young nurses who were top of the line. They got all the top grades at their school, and they figured, well, you know all the knowledge. But they didn't have the experience. So there was this kid who was being looked after, one of the brightest nurses, but the nurses found the kid's periphery, their hands and their feet were cold, and they're looking a little bit out of it. So, oh no, it's a cold day outside, so I'm going to put bags of normal saline to keep the baby, keep the child warm, not realizing that was a type of shock, and the patient was bleeding internally, the child died. So that's where you have economic cutbacks or what have you, in affecting the institution, which indirectly affected the nursing, the quality of nursing, and that patient died. And I was at the coroner's inquest, and this poor resident was crying his eyes out. I'm sure he has PTSD by now, taking all the blame for himself for not having checked on the patient, although he followed protocol. The protocol and the guidelines, that could give you a false sense of security. Okay, put that back now. Other things I have to mention. Right now, I think I created a lot of havoc, perhaps a CHIO, so we had a gentleman's agreement that I sort of departed CHIO a few years ago because of my excess qualifications. I work now outside a hospital. I work at a walk-in clinic, and you're addressing everything within the hospital confines, but nobody's thinking about the large majority of patients out there who are stimulating and continuing the superbugs and to grow, because they come and they look at you and they have their internet information in their hand, and they say, what's wrong with my kid? And I make the diagnosis, and they say, hang on a minute, doctor. Yes, you're right. I give the diagnosis, so they have the stuff off the internet, and they believe that anything on the internet is God's truth, and they come with you to check you out, okay? So that is something we have to battle against out there. You have to have the confidence to stand up. Now, what works is education. I have to say, listen, remember the program on TV about superbugs? If I give you antibiotic, it's superbugs. And the child says, oh, doctor, I say, yes. So you go home, come back in a couple of days, time and so. So the internet challenges are there all the time, and we have to be able to stand up firm. It's you and the patient alone in the room. You don't have Dr. X from upstairs to come down and support you. You just have to say, well, too bad if you're not. Here's the name of the college. Write them and tell them. You understand? You have to be sure what you're doing. Now, I wish you mentioned that the UK had a prize of $10 million. I'd like to support that. The reason being is that to do the test to detect what kind of bacteria you had is affected by time. Your patient is going down the tubes, but you're waiting to see what the test said. If the test cell is A, B, or C bacteria, and this $10 million prize will be really, really helpful, because if the test results can come much sooner, then you will know exactly, quicker what antibiotics you can use, and thereby reduce the possibility of superbugs. So I deal a lot with the immigrants who come in. My walk-in clinic is in Toronto, and they bring, of course, the bugs with them. They bring the antibiotic that they bought off the street in whatever country, and they say, well, I pass a little bit. Can I take my son's antibiotic, doctor? I say, well, no, you're not supposed to, but they already started taking it, but they come to check you out and see if they're fine. What else could I deal with? I agree with I just made a few notes as I went along. The dentist and the liability. It's fine to say that CMP does well. They hold your hand and tell you it's all right, you're not to blame. But then it takes sometimes months and years. By that time, your self-confidence is going down. You're losing sleep. You turn away from your wife. Your practice tends to start to suffer. And you essentially have, I think, PTSD. Okay, these physicians, they fall off and they say, something? Nobody looking at me give the antibiotics, so at least I'll have a comfortable life. Too bad if they find a superbug. It's only one. They always think I'm the only one giving the antibiotic totally, and do not realize that there are a lot of us physicians giving the antibiotic also. I agree with the accreditation of hospitals, but that is hospital. There's nobody out there in the community giving us accreditation. Dentist fear, PTSD. Again, what helps with superbugs is education of the public. If any TV program that's dealing with illness, if they just mention by the side superbugs, it's going to help us out there who are dealing with the massive amount of patients out there who want an antibiotic. And then they do doctor shop. They go to that clinic, they didn't give me anything. So they come the next afternoon to the other clinic, and they run around until they give them something. The other thing I wish people could create is a placebo. A placebo is a medication you take that has a psychological effect of making it. I wish I had blue water and pink water and say, write it and give them to take, because even before they leave your office or leave the pharmacy and they take one, they start feeling better. We need placebos. Okay, if somebody will create placebos, they'll make a mint. I think that's about all I need to say. I can go on and on and on, but I'll take some questions.
Thank you, Dr. Horsham. That was the most important segue there. For just to be clear, we have been talking about hospitals and use in hospitals and the law and liability with respect to hospitals, but 85% of antibiotic use in the human population is prescribed in the community. So there's an awful lot of focus and attention that's required on that, and that will be dealt with this afternoon as well. So I want to see if there are any questions for Dr. Horsham. Yeah. I wanted to build a little bit on, maybe the interrelationship between the community and the hospital. Sometimes, of course, we have people picking up an antibiotic-resistant organism from a hospital and going into the community. A phenomenon seen in the States, though, has been that some of the most resistant organisms, the CPEs, have had their reservoir in long-term care facilities where there's vast overuse of antibiotics for urinary tract infections. Those facilities then seed the hospitals, and the hospitals run into big problems. I'm wondering what whether there's a legal angle on that. I've seen it as a health issue, but I've not seen it as a legal one.
So I talked a little bit about California and their stewardship laws, and they're actually either have or are about to expand those to long-term care homes. And so, of course, long-term care homes don't have the same maybe capacity for the level of programs that a hospital does. And a lot of the hospitals are actually run by infectious disease specialists, which a long-term care home wouldn't have. But, at least, that will get them kind of thinking about that issue. So that's one kind of law reform that is going on.
Yeah. John.
Yes, just a hypothetical question. So what would transpire in a setting where, for example, and I don't know about Ottawa, but in the Netherlands, the tulip industry, they use huge amounts of antifungals because they don't want any of the tulip bulbs. And they dip them literally in antifungal agents and then plant them. If you were a tulip farm worker and developed a fungal infection and it was totally resistant to all of the antifungals, would you have any legal rights to be able to look at your employer who uses these antifungals in the tulip industry? This might also apply to abattoirs and the food industry and elsewhere.
It depends on the standard of practice, because if you got the fungal infection on your fingers, we go back to basics. Did you use the protective gloves, etc., etc.? Did you take quick action as a physician? Okay, because sometimes you can trap it. Because your body has got a lot of protective mechanisms on board in all the juices and secretions, even before you get to the antibiotic stage or the fungal stage. Again, and we refer to the standard of practice of the tulip industry that could be used to protect any further liability. But for his point of view, did he act quickly? Did he use the protective mechanisms? Did he go immediately and get some stuff done? Because if it's a fungal infection that is local, that sometimes that injured tissue, as you know, could be excised. Okay, and then you could build the patient up with the fact that the body will work much better than waiting for an antifungal to be sent from across the US or what have you. But so it's just immediate action, okay, on the standard of care, standard of average.
Thank you.
So, Dr. Horsham, you're a pediatrician. The area of human medicine where we've seen the most dramatic declines in unnecessary use of antibiotics has been in pediatrics for things like treating middle ear infections and other upper respiratory infections. And it's been much more dramatic than in the adult population. Has there been blowback? Has there been a lot more pressure back from parents, or is the culture changing?
Well, I love dealing with parents who come from Europe. I don't know what they do in Europe, in the European countries, but they are the ones that beg you, don't give them antibiotics. Okay, give me the prescription. I will wait for another 24 hours. So I think whatever they do for the parents in Europe, somehow it's embedded in them, antibiotics are bad for your kids. And when I read an article, they were saying that children are essentially, from an economic point of view, kept at home until the age of 4 or 5 years when their protective system is mature enough, okay, to ward off the viruses and bacteria, especially the viruses that you get, because we have something we call the daycare syndrome, okay, because the kids start at the age of about 6 months to go to daycare, and they come in for about 9 months, they're having all kind of runny noses, they got constant runny noses, cough, fever, but they look fine, but it's a matter of getting to the parents and said, look, this is part of getting out in the community. So it's a matter of being firm, but again, we could do it some help by educating parents as they leave the nursery with the baby and said, look, when you start going to nursery school, you're going to get a lot of bugs and infection, and sort of give a little bit more criteria. So I like dealing with the European parents. They're easier to convince.
I was never sicker than when my kids were that age. We have open floor time for any of the panelists if there are any last questions before the break. If not seeing that, I'd like you to ask you to please join me in thanking the panelists for this interesting round of discussion.
Very strong life. God bless her, she's dead now. She phoned me and said, I have this cough, it's going on for weeks and months, and the doctor wouldn't give me anything. So I was going back. I'm from Trinidad, and I took her home because I said, you may have a mycoplasma pneumonia. I'll give you some specific antibiotics. So I got home, and I said, dear, you have 14 days of antibiotics. You can take it. So I went out the next day, and I came back, and she had a suspicious look on her face, like the cat with the cream. So I said, what have you done? Well, I took water of the doses, and it made me feel better. So Glenda, my sister, passed by and had the same cough. So she gave her one of the tablets to go home and take. So those are, they share the medication out in these countries. And somehow, I think they'll put the drug companies out of action if they concentrate all their trade down there.
Okay, we're headed for the break. We're back at 11:30.